Bonjour, bienvenue, Monsieur, Mesdames, and thank you very much for joining us for another research rounds. And this is a very special one on a very exciting topic. And just before we start introducing our esteemed speaker, Dr. Sun, just remember in terms of logistics, and most of you are super familiar with this, in that if you have questions during the presentation, you can use the Q&A feature on the bottom of your screen to pose those questions, and we certainly will endeavor to answer all of them at the end of the presentation. And we'll also be accepting live questions. So if you'd like to join the discussion panel, please use the hands up feature, and then Kelsey or Allison will be able to then help you to pose your questions directly. In addition, if you have any technical issues, please use the chat feature, and then Kelsey will be able to make sure that we can troubleshoot and bring you into the presentation. So we're absolutely delighted today to have Dr. Christopher Sun, and who's really a superb system analyst and a system designer for health systems, but also using AI and other tools to really actually provide insight into this very exciting area. He currently is the visiting assistant professor of operations management at the MIT Sloan School of Management, and he through the collaboration with University of Ottawa's Telfer School of Management, we are very fortunate to be able to have Chris join our faculty in the fall at both Telfers and also at the Hart Institute. And this is really the first type of a joint recruitment of this nature at the University of Ottawa. So we are totally thrilled. And Dr. Sun's research interest lies at the intersection of optimization, artificial intelligence, public health, and health equity. And his research primarily revolves around the utilization of data-driven optimization processes using machine learning and simulation techniques to inform the development of public health policies and the optimized improvement in design of health systems. So this is going to be super important for not only our own research, but really health of Canadians. And Dr. Sun has conducted his research with collaboration with multiple major health institutions and systems, including the Massachusetts General Hospital in Boston, the Boston Emergency Medical Services, St. Michael's Hospital in Toronto, and the Toronto Emergency Services Group, and also the Gentofte Hospital System in Copenhagen in Denmark. He originally received his BSc in engineering science, and with a focus or concentration on biomedical engineering, and then PhD in industrial engineering from University of Toronto. And then most recently, he's a postdoctoral fellow at the Massachusetts Institute of Technology's Sloan School of Management, and at the same time at the Massachusetts General Hospital. And is recipient of a CIHR Vanier Canada Graduate Scholarship and our American Heart Association Young Investigator Award, and has been named as the Citizen CPR Foundation's Top 40 Under 40. This is fantastic. And he has published in top journals in cardiovascular medicine, as well as in system management. And we're really fortunate to actually be able to recruit him because he had many other job offers as our Canada Research Chair Tier 2 candidate, and also assistant professor at the University of Ottawa. And he'll be able to join us in the fall after his stint of teaching in this area at the MIT. And so we are all excited to welcome Dr. Sun to join our faculty. And but particularly also look forward to his lecture today, which is entitled Actionable Analytics in Healthcare, from Cardiac Arrest Response Strategies to Intra-Hospital Patient Transport Systems. This is really fascinating. So thank you so much, Chris, for joining us. And the floor is yours.
Thank you so much for the introduction, Peter. I think first off, thank you again for inviting me to speak at this seminar. It's really an honor, and even more so, I'm very lucky or feeling very fortunate to be joining this group, this wonderful group. So I look forward to meeting many of you or all of you in person this September. Right, so let's see, alrighty. So yes, as Peter kind of summarized, the whole idea of this talk is to kind of really highlight how these data analytics techniques like optimization, prediction, and simulation modeling can really inform decision-making in healthcare. So in this talk, I'm really going to focus on two different types of examples of how this can be. And one is kind of focused more on, I guess, a more clinical problem in nature, improving cardiac arrest survivals through kind of strategic or optimized automated external defibrillator placement. And the second topic is more focused on logistics, hospital operations related to intra-hospital patient transport systems. So I'm hoping that these two projects will give you kind of an idea. It's in no means supposed to be comprehensive of what you can do, but kind of give you two flavors of the work that I've been doing and the work that I'm interested in. And I think one more kind of point, if we have time, hopefully I'll try to make it through all the content, but I also want to give some examples of some fairness frameworks that can be actually integrated into these optimization approaches to kind of open the doors to discussions about how do we actually try and reduce health disparities in a very explicit way. So these are kind of the three, I guess, topics that we'll be talking about today. And yes, I'll try to monitor the Q&A as they come in and do my best to answer questions as we go along. So the first topic around optimization of AEDs or external defibrillators was recently published in the Journal of American Heart Association and is joint work with clinician collaborators at both Toronto as well as Copenhagen, as well as my PhD advisor, Professor Timothy Chan at U of T. So out-of-hospital cardiac arrest is an extremely deadly emergency event. And as many of you know, it occurs when there's a sudden electrical malfunction of the heart, which leads to a loss of consciousness, a loss of blood flow, and most often it results in death. Now, on top of being one of the leading causes of death in developed worlds, it's also a huge financial burden on healthcare systems. So out-of-hospital cardiac arrest in particular is a really challenging public health issue for two main reasons. First, it can occur very suddenly without warning. So it's estimated that around half of all victims are not previously diagnosed with heart disease when it occurs. And among them, and even kind of more specific than that, around 30% of all victims, cardiac arrest is estimated to be the first manifestation of the patient's heart disease. So it can occur very suddenly. The second main challenge is that survival rates of these out-of-hospital cardiac arrests are only around 11% overall. And part of that is survival actually decreases significantly for every minute without treatment. So this figure here really shows how survival decreases exponentially over time. So one of the things that makes cardiac arrest very unique is that it can actually be treated by regular bystanders through the use of an automated external defibrillator, which is usually housed in cabinets like this, placed in public locations. And an AED is essentially a very portable medical device that you can apply onto a collapsed victim to deliver defibrillation and reduce the time to treatment and thus increase survival rates. And we can clearly see that early bystander response through defibrillation and through AEDs can lead to survival rates that are more than 5 times greater than overall survival rates, and can even lead to improved outcomes compared to when first responders provide treatment first. And this is as intended. So pretty much based on the effects of AEDs, the question becomes, how do we actually facilitate and increase bystander AED use to improve survival? So there are many different factors that play into increasing bystander use, like bystander presence and a willingness to act. But I think one of the most fundamental aspects is the actual placement of an accessible AED nearby. So based on this notion, or accordingly, health organizations like the American Heart Association and the European Resuscitation Council have spent a lot of resources developing these public Aed placement guidelines to help increase the number of AEDs that are disseminated across city settings. So previous examples of these guidelines can be summarized here, which is effectively placing AEDs in high-risk locations or locations rather where historically cardiac arrests have been occurring. So this can be airports or racetracks or casinos or so forth. But the challenge is, despite kind of these years of advocacy and dedication of resources, AED use remains quite low in the public setting, and even lower in the private setting. So AED use occurs in less than 15% of all public cardiac arrests. Now, when we think about the challenge of trying to place AEDs in a strategic manner, this problem is actually very common to a lot of different settings. So we're trying to make decisions under uncertainty of the future. So we don't know where future cardiac arrests will be. And kind of on top of that, we want to make sure that the resources that we're placing into this problem are really maximizing our chances of improvement. So maximizing utility of our resources used. So this notion motivated the use of mathematical optimization or constrained optimization to support decision-making for AED placement strategies. And generally what these models do is they use historical cardiac arrest data as an input to identify kind of these patterns and incidents. And they suggest future AED placements or AED placements to cover future cardiac arrest incidents. So we're taking in historical data suggesting AED placements to cover future cardiac arrests. And there's been a growing body of literature that actually shows that these optimization techniques are quite promising in this space of AED placement strategies. Previous work has demonstrated that optimization can outperform population-guided heuristics. So pretty much placing AEDs in highly populated areas or areas with high population density, as well as even real existing AED networks themselves. So given kind of these two approaches, a very natural question comes up of how do optimization-based AED placement approaches compare against the gold standard of these international AED placement guidelines. So in this project, we actually conduct the first head-to-head comparison of these two methods through an in silico trial using data from Copenhagen, Denmark. So before going on, we can ask ourselves, what exactly is an in silico trial? Well, it's effectively a computer simulated trial using observational data. And there are two main benefits to an approach like this. So first, it can overcome a lot of the costs and logistical barriers associated with an actual clinical trial, where you would have to recruit enough patients and have the experiment conducted for a long enough study period. And second, we can really assess the experiment arms over the exact same study population. And in doing so, we can really isolate the impact of the intervention we're looking at. We can also think of this as this in silico experiment as a counterfactual analysis with causal certainty of the primary outcome measure. So in our case, in our specific study, we actually use a primary outcome measure that is based on distance from an AED to a cardiac arrest. And we think this causal certainty notion holds under the assumption that cardiac arrests occur independently of where AEDs are placed. So in other words, if we place an AED in the room that you're in now, it's not going to cause or prevent a future cardiac arrest from occurring. So with that kind of assumption, which I think is fairly reasonable, but please let me know if you disagree, we can effectively use our data as is and then measure with certainty these distances that we use for a primary outcome measure. So in terms of the framework that we used in the study itself, it's really composed of two stages. So in the first stage, we have our simulation framework where we simulate and calculate the primary outcome of our two approaches. And then in the second stage, we estimate patient outcomes based on the primary outcome measure that we simulate. So in order to compare these two approaches, we first had to come up with a control. So we first had to operationalize and translate the guidelines text into a placement heuristic that we could actually follow. So taking a look at the guidelines text verbatim, we have AHA recommending placements where there's a relatively high likelihood of witnessed cardiac arrest, and the ERC, European kind of body, doing something very similar. So places with a high density of citizens, as it is here, cardiac arrests are often witnessed. So right off the bat, this is kind of vague text. So we actually spend a lot of time with our clinical collaborators trying to develop a placement heuristic. And kind of the trade-offs where we wanted it to stay true to the nature of the text, but still have it be easily understandable and implementable by lay communities. So the ultimate approach that we developed was this 24/7 available AED placement at every unique location of a witness cardiac arrest. And the 24/7 availability was one important component that we made sure to include because of our previous work that showed the harms of limited temporal AED availability on kind of coverage and outcomes. We found that 1 in 4 cardiac arrests in Copenhagen actually occurred nearby an AED when that AED was locked behind closed doors. So in terms of the intervention, we used a mathematical optimization model to guide AED placement decisions. And what models like this do is either maximize or minimize a given objective function. So in our case, we designed our model to select AED locations that maximize the number of historical cardiac arrests that occurred within 100 meters of an AED. And we actually call this metric cardiac arrest coverage, and we use it as our primary outcome measure in the study. The 100-meter coverage radius that we used in this definition is based on previous guidelines that recommend defibrillation within 3 minutes of collapse. So 100 meters is roughly how far a bystander can go to reach an AED, bring it back to the patient, and apply it on the victim within 3 minutes. In terms of the model inputs, it uses cardiac arrest, historical cardiac arrest data, which we got from Copenhagen's registry. And we also used a set of candidate AED locations to consider for placement. And this was effectively just the intersections of a 15 by 15 meter grid that spans Copenhagen. So you can also think of this as having very few constraints on where we could place AEDs, potential AEDs. And finally, the model outputs this optimal set of candidate AED locations to place AEDs to maximize our objective cardiac arrest coverage. So to preface some of the results, I want to share some intuition on the benefits of centralization as well as optimization in comparison to decentralized approaches like with the guidelines. So let's walk through this toy example here. So let's say in this area, we have 2 witness cardiac arrests shown as these red dots here. So if we were following a decentralized guidelines-based approach, decentralized decision makers will see these witness cardiac arrests and place AEDs accordingly. But on the other hand, with optimization and a centralized decision maker, we can look at the full picture and say, hey, we only need 1 AED to cover both of these cardiac arrests according to our coverage definition. And we can use the resources saved to provide more coverage elsewhere. Right? So kind of continuing on with this example, let's say more time passes and another witness cardiac arrest occurs nearby in this area. So in this decentralized approach, we can already see it's already covered, but because the decision makers don't talk to each other, they don't know that, so they'll end up placing another AED at that location. On the other hand, with optimization, we can see the decision maker already sees that it's covered, so we can again save more resources to provide more coverage elsewhere. And this might seem kind of very straightforward, but when we think about making these decisions across a large study area with a tremendous number of cardiac arrests, finding the right combination of placements is very difficult, as you can imagine. So this is really the benefits of optimization to handle kind of these large scale problems. So what we see here is actually a heat map of the historical cardiac arrests across Copenhagen, overlaid by these diamonds, which are the optimal locations that were optimal AED locations that were selected by our model. And these diamonds are color coded based on the number of future cardiac arrests they ended up covering. Right, so intuitively in the downtown core, you would get more coverage. All right, coming back to kind of the study design, we had a 9-year trial period, which is again is one of the benefits of our simulation-based approach, because this is much longer than a traditional clinical trial, which is typically around 2 to 3 years. We set our control, our placements based on current guidelines, and our intervention an equal number of optimized AED placements as in the control. And again, both of these are placed with 24/7 availability. And finally, we measure our primary outcome of cardiac arrest coverage. And again, this was based on distance, because distance is something we can calculate with certainty compared to something more complex like patient survival. So how did we actually conduct the experiment? I see a question. Let me just pull it up. So within the historical data that you used in the model, in addition to locations, were actually used after they were used. That is a very interesting question. So I don't think we've explicitly looked at the impact of witnessed bystander witness arrest on AED use. I think that is the question, but maybe we can talk about that after. There are certain additional characteristics within the data set in Copenhagen, so that is certainly a possibility to do. But yeah, so maybe we'll talk about that after the presentation. Thanks, Jody. I think I also realized that answering questions on the fly in the text form is kind of challenging, so maybe we'll just save all the questions for the end of the presentation. All right, so coming back to the visualization of the experiment, or how we actually conducted it. So let's start off with the control. So let's say over time, we have cardiac arrests that are coming or occurring in different locations and spaces around Copenhagen. And kind of the really goal of our simulation approach is to replicate as close to what an actual clinical trial would look like in real life. So based on that, we set the start of our trial date to be January 2008, because prior to this time, Copenhagen EMS actually didn't collect the witness status of the cardiac arrest. So we wouldn't be able to follow the guidelines approach if we wanted to. From 2008 onwards, we split up the rest of the trial period into these destroyed time intervals, where for each of these intervals, we looked at the previously occurring cardiac arrest, identified unique witnessed arrest locations, and placed AEDs accordingly. So for example, for time period 1, we looked at the previously occurring cardiac arrest, identified any unique witnessed arrest locations, and placed AEDs in batch at the end of the month, or at the end of this time period accordingly. So for time period 2, we did the exact same thing. We looked at the previously occurring cardiac arrest and any new witnessed arrest locations and placed AEDs again. And we continue to do this for the remainder of the study period. Right. So now going with our optimization intervention, you can imagine this as pretty much a parallel universe with the exact same study population and the exact same study setting. So again, we set the start of the trial to be 2008 and created these disjoint time intervals. And for each of these intervals, we optimized an equal number of AEDs as in the control. So for time period 1, we looked at all of the historical cardiac arrests, looked at the number of AEDs that were placed in the control, plugged that into our optimization model, and optimized an equivalent number of AEDs. For time period 2, similar thing, previous cardiac arrest data, the number of AEDs in the control, and also the locations of the already placed AEDs, because we want to kind of build on the existing network in a very constructive way. So plugged all 3 of those inputs into the optimization model and optimized again. And we repeated and then calculated the resulting cardiac arrest coverage. So the final time periods that we used, these durations were 30 days long. So you can think of this as monthly deployments. And I think the last thing that I want to point out is we're not being clairvoyant in any of these situations. So we're only using data from the past to inform our decisions, and then we're calculating kind of the future cardiac arrest in each of these cases. So this is what we found. So over here on the y-axis, we have cardiac arrest coverage, and on the x-axis, we have time. So we can see coverage growing as time progresses. So in our control approach, we found that around 400 AEDs were placed, and they provided around 16% coverage of all the cardiac arrests during the study period. And with optimization, using the same number of AEDs, provided 24% coverage of all cardiac arrests. And this translated to a significant increase of around 50%. Now, to add more context to these interventions, or to these kind of arms, we also calculated the coverage of the real existing AED network in Copenhagen. And this network consisted of 1,600 AEDs and only covered roughly 14% of all cardiac arrests. So based on kind of this context, we can see that first, the control guidelines approach that we developed is actually quite strong. And it's not like that we developed some kind of bad performing intervention to make optimization look good, but rather it even performs better than the true existing AED network in Copenhagen. And I think the second thing to notice is that the existing network is very inefficient. So it places roughly 1,600 AEDs to only cover around 14% of cardiac arrests. So we also wanted to see if our results would hold for different scenarios. So we repeated this experiment with limits on the number of AEDs that we could place in both approaches. So for example, this first bar graph or bars represent the differences if we could only place 50 AEDs or 100 or 150 and so forth. And what we found first was significant improvements throughout all scenarios, but also the largest improvements were found in the most resource constrained situations. And I think this is important because for communities that don't have enough resources to follow these guidelines to their entirety, they might have difficulties prioritizing placements on their own. And this is really where optimization, again, has a chance to shine, because these models can incorporate the specific resource constraints of the stakeholders or the decision makers that are using that model. So they can be quite beneficial in these scenarios. So while cardiac arrest coverage is a very easily quantifiable metric that we can use to measure performance, I think it's only one part of the picture. What we're most interested in are changes in patient outcomes like survival and so forth. But at the same time, these outcomes are a lot more complex. They depend on patient demographics or patient information like age, sex, and they also depend on other response characteristics, like if bystander CPR was performed or bystander witnessed the arrest and so forth. So what we did was we developed multivariate logistic regression models to first translate cardiac arrest coverage to patient outcomes, and then second, estimate the counterfactual patient outcomes from our simulated AED placements. So in other words, we developed these models to predict patient outcomes based on the new coverage values from our optimization and guidelines-based approaches. So we trained our prediction models using the historical cardiac arrest data from Copenhagen again, and the AED coverage values from the real AEDs in Copenhagen. And we did that for two models, one for bystander defibrillation and one for 30-day survival. And these models control for patient characteristics, like I mentioned, and response characteristics, response time, witness, CPR, as well as AED coverage, which we'll be kind of modifying to get our estimates. And this is what we found. So based on our estimates, we found bystander defibrillation increased by, had a relative increase of 16.7% and 30-day survival 4.2%. And the first thing to notice here is that these improvements are much smaller than our cardiac arrest coverage improvements. But again, this is expected because of the kind of different factors that play into these outcomes. But I do want to point out that both of them were still significant. And generally, after talking with our clinician collaborators, they kind of recommended or added that a 5% improvement is generally the threshold for a successful intervention. So we're really not too far off from that. I think one more thing to point out is that in Copenhagen, survival outcomes for cardiac arrests are way above kind of North America with around 30%. So it's also possible that there's kind of less room for improvement through AED interventions. And one of the reasons for that is that I believe their bystander CPR rates are around 70%, 60 or 70%, which is incredibly high. So pretty much to summarize, we saw in this project that optimization models can outperform these guidelines-based approaches, both in terms of cardiac arrest coverage and estimated patient outcomes. But also, both optimization and guidelines approaches can outperform the real existing AED network in Copenhagen. So this really emphasizes the value of centralized decision makers, optimization, as well as 24/7 accessible AEDs. And again, highlights how these data analytics and these models can help validate and support the operationalizations of different interventions, and in this case, AED placement strategies. All right, so kind of moving on to the next example of how analytics can support decision-making, I want to jump into the in-hospital setting and kind of shift gears into some problems that are more logistics focused, and specifically with patient transport services. And this is joint work with Professor Rfid Tags at MIT, as well as doctors Martin Copenhaver and Cecilia Zenteno at MGH, Massachusetts General Hospital. So logistics, I think in healthcare is a essential but costly aspect of hospital operations, and it accounts for roughly 20 to 45% of a hospital's operating budget. And one of the, I think, overlooked but ubiquitous parts of logistics is intra-patient hospital transport services. And what this service really entails is the transport of patients within the hospital itself. So you can think of ED to a care floor, or a care floor to a test site, and so forth. So you can, as you can imagine, this is really essential in progressing care and patient flow within the hospital. In fact, delays related to transport services can lead to the underutilization of scarce hospital resources. And in most extreme cases, it can lead to missed appointments even. And this can be very financially burdensome when we're thinking about high cost services like MRIs or operating rooms. And along with this, delays or kind of these prolonged completion times of transport requests can also be very taxing for care teams themselves. Most transport systems operate in a very Uber-like dial-a-ride system where care teams have to kind of predict how early to put in a transport request to meet their appointment time. And if care teams miss that window, most systems can be very unforgiving in terms of reprioritizing those late requests. And finally, generally with transport, there are risks of patient safety events. And this is because when patients are transported, they're displaced from their primary care teams, and they might not receive the same levels of continuous care as they normally would. And this is most relevant, I think, for critically ill patients who are kind of more sick in general, but also have a tendency to be transported more often for procedures and diagnostic tests and so forth. So Massachusetts General Hospital is actually unsurprisingly, is no stranger to these transport service challenges, as it is one of the largest teaching hospitals in the US. Now, on top of the tremendous number of patients that they serve every year, which corresponds to roughly 300,000 transport requests per year, the hospital itself just spans a very wide range or wide area. So it spans roughly 12 acres of land, and you can think of this as 30 hockey rinks. and that's a very far kind of area to traverse, especially as a transporter. We also have this vertical travel component with the highest floor in the hospital being 22 floors up. So given the size of MGH, they also have an equally large transport service group. And it's really composed of 3 main groups. And there are roughly, on median, 80 patient transporters working every day. And along with that, they have a sizable inventory of patient stretchers and wheelchairs, which are actually used to bring patients across the hospital through these services. But what really was the challenge here was that over time, MGH was seeing this worsening of patient request or inpatient transport request completion times. So here we have for central services, central transport services, which is the largest of the 3 transport groups at MGH, the completion time from when the request was submitted to when it was completed from 2019 to almost present day. Now, central transport has this 45-minute target completion time, which is shown by this red line here. And we can clearly see when we look at the this bar relative to the completion times, this worsening trends. And more explicitly, if we looked at the proportion of requests that are exceeding this 45-minute completion time, we can really see how worse things are getting. So starting around 15% back in 2019 to all the way up to 30 to 35% in 2021 or 2022 as well. So I guess the healthcare systems engineering group, and myself included, were tasked with this project to investigate, evaluate, and redesign MGH's patient transport system through data analytics. And we pretty much did this in 3 steps. So first, we performed this diagnostic and qualitative investigation, speaking with stakeholders, speaking with care teams and managers to really understand what are the key root problems related to these increasing completion times. We performed a prescriptive analysis where we developed this discrete event simulation model to assess particularly an intervention related to the assignment of transporters to requests. And we specifically did this for central transport services again. And then third, we actually piloted and implemented our solution and assessed the impact through some time series regression modeling. So to just give more context on the structure of MGH's transport services, like I said, it's composed of 3 main groups. So we have central transport, the emergency department transport, and the operating room transport. And these requests or these services have kind of non-intersecting responsibilities in terms of who they provide transport for, but you could, but in certain scenarios, they can pool resources for their requests. So central transport is generally responsible for inpatients from care flows to test sites and back. They also have a set of dedicated transporters for more specialized services, dialysis, MRI, and ICU. The ED transport team, unsurprisingly, takes care of ED patients, but they also have this unique role of transporting admitted inpatients from the ED to the care floors. And among this ED transport group, we also have this ED radiology subgroup, which has serves kind of more frequent trips, but are much more short. So kind of really rapid short trips. So they have another dedicated team for that. And finally, we have the OR team, which is primarily for these surgical procedures. And just to give you an idea of how overlooked these transport services are within kind of leadership and stakeholders, we actually found out that, or we realized that operating room transport actually still record their trips on paper. So there were no electrical records that we could actually use for the for this project. And accordingly, our analysis is primarily focused on central transport and ED transport and ED radiology. But fortunately, I think because of this redesign, where the OR transport team is now migrating onto an electronic record system. So what does a transport request actually entail? Well, there are 4 main kind of timestamps or checkpoints, and this corresponds to the timestamps that we have available in the data. So I'll just quickly walk through this, this process. So first, the request is submitted by a care team. And then whenever a transporter is available, it will then be assigned to that transporter. And from there, if the transport is coming from a care floor where the patient is still on an inpatient bed, then the transporter needs to locate and find an unused stretcher or wheelchair to actually put the transport or the patient on, which would take time because of how kind of busy the system is and how stretchers are located in an ad hoc manner across the hospital. So if they need to do that, they do that first. But if not, they travel straight to the pickup location and then they begin their first handoff with the care team. And again, this would take a while if the care team is busy with other tasks and they're not available at the time. Following that, they'll physically move the patient onto the stretcher, which could also be challenging based on the state of the patient itself. So next, we can mark, or the transporters can mark the request as in progress. And from there, they can travel to the destination location, have a second handoff with the destination care team, and then mark the request as completed. And if they did have a leftover stretcher after their trip, and if they don't need it for their next request, they'll typically just drop it off in the hallway nearby their location. So we can actually categorize these processes into three distinct time periods or time duration. So we have the in-queue time, the setup time, and the transport and drop-off time. And as this figure kind of alludes to, what we actually found was the majority of the request was spent in this setup time phase. So in other words, really for most of the requests, the transporter was not actually transporting the patient. They were doing these auxiliary tasks. So to be more specific, here are the breakdowns of the setup time versus the drop-off times for central transport, ED transport, and ED radiology. So as you can see in central and ED, this setup time is nearly twice as long as the actual transport and drop-off time. So again, the minority of time is being spent on physically actually dropping or transporting the patient from site to site. And the reason why the ED kind of graph right here kind of has the opposite effect is when the ED transporters are bringing patients up to a care floor, they're actually making this round trip to bring an empty stretcher back down to the ED before marking the request as completed. So really, this is another inefficiency, but another type of inefficiency, but you can also think of this as emphasizing the point that, hey, we're spending a lot of time not actually transporting the patient during these requests. So what we think is if we can target this setup time and reduce this setup time, in turn, we can hopefully improve overall system performance and reduce these in-queue times. Now, how would we actually do this? We pretty much identified 4 possible interventions that we could explore after talking to stakeholders. And they're pretty much as follows. First, we have this targeting this naive first in, first out transport request system. Second, we could target the uncertainty in stretcher locations. So have some more strategic locations, and you can think of this as a parallel to the AED problem. We could work on improving the handoff times, or we can think of a complete restructuring of the system and remove these disjoint services. So we ultimately decided on this, on the assignment request system, because we thought that maybe if we solve this problem, we could in turn implicitly affect the other problems that we were seeing. So what is the current assignment system anyway? So like I said, it's a first in, first out system, and really a single queue system where requests with the largest assignment score are assigned first. And these scores are increased based on time in queue and request priority. Now, ideally, we would like to kind of develop this routing, optimal routing system where we could really kind of dictate where transporters should go throughout the day. But because we had the end goal of implementation in mind, we had to work in the constraints of the existing system. And that system actually had very rudimentary functionality in terms of how we could improve the assignments. In fact, the only lever that we could really pull was this proximity-based request assignment, where scores of requests nearby a transporter are prioritized based on this a binary indicator of whether they're nearby or not nearby. So let me walk you through how that is actually done. So the actual decision that we're trying to make is that each area or floor must be assigned to a single proximity group. So this is ultimately what we're kind of deciding or optimizing over. So in this example, let's say we can divide up our group into three, or our building into three groups. And from there, we follow this algorithm, this assignment algorithm. So just walking us through this. So first, let's assume that the transport request is completed in group one. If there is a pending request that exists on this floor, then we're going to prioritize that request. If there isn't one, we're going to go back to our first in, first out system on the other remaining groups, right? And then at the end, we're just going to prioritize, we're just going to assign the request that has the highest prioritization score to the transporter. So in this case, let's say there was one request on the second floor, so that ultimately, at maybe the expense of some queue skipping in the other locations, this is what was ended up being assigned. Yeah. So when we think about the system, there's actually this interesting problem with this grouping granularity trade-off. So where highly granular and coarse groupings actually converge to the same performance as our first in, first out system. And this kind of figure, I guess, highlights the intuition behind that. So let's say in our granular grouping side, we have a group for each of these floors. And for the coarse grouping, we have one for building A and one for building 2. And we can think of a transporter just finishing a request on the 3rd floor, and there's no pending request on the 3rd floor. So very naturally, when the granular group, you can see how obviously this returns to a first in, first out set, first in, first out queue. But with the coarse grouping, we can kind of still get some benefits of proximity-based assignments, but there's still a risk that the patient has to traverse through the whole building to get to their next request. And this kind of, so you can imagine there's some sort of optimality curve, and that kind of implies the notion that there is some optimal groupings that we can discover to reduce completion times overall. And this is what we show through our simulation model. So I think out of the interest of time, I'm going to really work quickly through these next few slides. But pretty much through these insights and after thinking this through, we developed a simulation model to evaluate different scenarios of these proximity groupings, ranging from most granular groupings to least granular groupings, to actually decide on what we would actually want to implement. So we validated simulation models, and this is kind of the notion that we saw after evaluating these granular and less granular groups. So first, I guess the metric that we're looking at is a request exceeding this 45-minute time. And the first thing to notice is we found that group 3, which is one of the medium groups or groups that were in the middle of the coarse and granular spectrum, we saw that this provided the most improvements relative to our control. And second, you can kind of see this very subtly here. We do see this U-shape, this curve-like behavior. And obviously this is more subtle than what we described previously. And that's because we're not looking at the extreme cases. But again, our simulation model follows the intuition that highly granular and coarse groupings converge to the same performance as the control. So based on this, I'll skip to kind of the interesting part. We piloted proximity grouping 3, and we saw significant improvements in completion times throughout the days of the weeks. So for example, for Monday, we saw a relative difference improvement in completion times of 30%, an absolute of roughly 18%. And for Fridays, we also saw quite large improvements. And this is important because the Mondays and the Fridays were the busiest days of the week in terms of transport service demand. And this comparison was pretty much done to kind of a 3-month period before and a 3-month period after the pilot. We also thought, okay, this is kind of an unadjusted analysis. So what if we could actually control for other factors that might be influencing this comparison to make sure we have a fair comparison? And we did that through kind of this regression model. I won't get into the details, but we can see the coefficients in this table here. And the one that really we want to focus on is this intervention coefficient. right here. So the outcome that we were looking at was mean completion time per day. And we saw that the intervention was associated with a almost 4-minute decrease in completion time. So it might not sound like a lot, but when we think about the number of requests, roughly 280 requests per day, this 4-minute, 4-minute decrease roughly translates to 17.5 person hours saved. So this is around 2 full-time transport workers per day. So pretty much to summarize, through this data-driven redesign of transport services, we identified 4 possible interventions to improve hospital services, transport services. We ended up focusing on the naive assignment system. We designed a simulation model to assess how different assignment strategies would work, and we ultimately implemented this into practice and saw this descriptively a 7 to 30% relative decrease in the number of trips exceeding this 40-minute completion time, as well as a significant association with decreased completion time through a time series regression analysis. Yes, and we're going to continue to monitor this and eventually think about developing a more rigorous optimized solution for these proximity groupings. So I think with that, I'll probably wrap up the presentation and maybe we can go to questions. Okay, break this in.
Okay, yeah, wow, okay, so yes, I see you have a few slides there on the equity as well, so which is fascinating. Yeah, so thank you so much. This is fantastic, and also I think these are real practical, real world, everyday problems, and but you know, it's daunting for us to actually figure out you know, these type of solutions, and we quite often just rely on intuition, and you know, so having the scientific approach you know, really I think adds a whole level of rigor in terms of decision making. And of course, it's going to have an impact on the quality of care, but at the same time, you know, you can see that it also helps in terms of resource planning and resource optimization. And I think you know, this is kind of a whole era of sort of really much more scientific thinking, right? You know, in terms of medical decision making, and so this is fantastic. So I don't know if there are any questions. I certainly have lots of questions. So please use the Q&A feature or hands up feature. And yeah, so I think you kind of addressed to a certain extent the question was about the witness, and I think you know, so you mentioned that it was a more recent data that appears to be more available. Yeah, I don't know if you want to answer that further, and I have other questions for you. Yeah.
Yeah, yeah, I'm just rereading it again. So AD, so witness, so I guess the notion of witness arrest is very important in terms of resuscitation. It's been shown to be strongly associated with survival and neurological outcome. So were there differences across locations in terms of witnessing and witnessing plus AD use? Yeah, I think generally the notion is, what's unique about EMS's system in Copenhagen is that their EMS system will actually direct a AED or a bystander to a nearby AED if there is one available. So their system is already connected in that manner, which I don't think a lot of North American cities are.
Wow.
So if there is one available, they can kind of direct it and use it to improve survival outcomes.
Wow,
Yeah.
that's really, you know, system-based thinking. That's amazing. So maybe I can ask a couple questions. One is on the strategy, you know, in terms of data gathering, and then the other question is actually more on the simulation side. So one is, you know, so for example, when I visited Taiwan, you know, they have actually a number of hospital systems that actually has huge data input. You know, so for example, all their mobile devices, including wheelchairs and everything, have, I think, the RID or you know, the codes on them. And so they know exactly where every device is in the hospital, including those that snuck out to the parking lot. And So yeah, so they use that information as a kind of a total input function to manage beds, sort of transportation, scheduling, and things like that. And so I don't know whether you think, having better data input is helpful, in these optimization processes. Maybe I'll just park there, ask you that one first, and I'll ask you the second one later. Yeah.
That's actually a fantastic point. So MGH also has these RFID tags, I think they're called, which provide these real-time trackings of these hospital assets.
Right.
I think the challenge is that you have all of these data sets, but you don't have systems that are yet communicating with each other. So this data is really stored in a separate system compared to Epic. So MGH uses Epic. So we have that data, but they don't talk to each other. So I guess the next aspect that these hospital transport groups are thinking about is, can we develop an app to tie them together? And then we can say, oh, there's a stretcher nearby, or oh, this request is taking a very long time. So yes, I agree that there's a plethora of data sets and data sources, but figuring out those connections is really a challenge. I think that's not unique to MGH at all.
Yeah. So, but of course, yeah. So the next question kind of relate to that to a certain extent, and so I was fascinated by the fact that you can do the so I see folks like David Burney and Jody Edwards are on the call here as well. So we do clinical trials, and of course, exactly as you mentioned, clinical trials are very time consuming and resource intensive, and we always try to find ways in which we can potentially at least sort of estimate the conclusions more robustly. And so I was fascinated with the fact that you can use quite a bit of a computational tools and the simulation to actually get answers pretty close to real world. And so I guess two questions. One is that can we in fact use this type of approach more before launching a clinical trial, because sometimes you do a clinical trial involving millions of dollars. At the end of the day, quite often you have no idea whether it's going to turn out to be informative or not, right? It's a bit of a gamble, and whether simulation can actually provide some confidence. In fact, this and then of course people will argue about different trial designs and setup, and nobody really actually knows, right? So is this a type of simulation can be helpful, in terms of achieving better design even for the trials, or in fact, ways to select patients and things like that. And if that is the case, is this a way in which we can? So the other thing that we want to do is kind of a more efficient trials, right? You actually do the trials on the population that most likely will actually be relevant and will actually make a difference, right? So we try to include everybody under the sun and hope something will work out. And of course, most of the time, majority of the patients don't really actually benefit at all from the program. So what's your thinking on that? It's kind of philosophical. Yeah.
Those are fantastic questions, and I think there are a lot to unpack, so I'll try to just summarize the thoughts very quickly. I think first off, it is important to recognize that we're not thinking about trying to replace like the gold standard of clinical trials at all, but really trying to think of how can we complement that. And in fact, I think there are certain, even in our space, like in the space of economics and operations research, there are certain people that think the only way you can test the effectiveness of an intervention is actually trying and actually implementing it. So even there's these philosophical debate, even I think it's just ubiquitous across all groups, all scientific groups. But with that being said, I think these simulation models can provide insights. I think there's the saying that like all models are wrong, but some are useful. So figuring out which questions that we can answer with modeling is important. Kind of related to that, a more specific example, I think, related to how predictive modeling even can assist in clinical trial design is there's some work that has looked on relating surrogate endpoints to a final patient clinical trial endpoint through kind of deep learning techniques.
Yeah.
So if we can kind of adjust accordingly, if we see that the surrogates are not looking too well, you can maybe adaptively end the trial or so forth. But I think there is a value in these simulation approaches that have not yet been kind of really translated into the medical community, but there's certainly methods that do explore this.
Yeah, okay, so that's super exciting, and I think, there are a lot of people who are interested in clinical trials, but also, others who are interested in potentially able to kind of connect the two. So this is, so this is really, really valuable. Yeah, so I think in view of the time, we'll probably wrap up this session, but I just want to thank you, in terms of fantastic work, really, really innovative and impactful as well, in terms of the saving lives, but at the same time optimizing resources, and really kind of underscores the power of having the right data, asking the right questions, and the right analytic approach, to actually solve real world problems. This is fantastic. So, we anxiously await, for your arrival. But this is a great session in which we get a chance to introduce you to a number of investigators, and we will set up, small groups both before and after your arrival, and so that we can really, start the exciting collaboration with your expertise. So thank you so much for taking time out, and look forward to, exciting ideas, and then having you being amongst our community. So thank you again, and thanks everybody for joining us. This has been a fantastic session. Yeah, take good care, everybody. Thanks very much again, Chris.
Thanks again for having me. All right, take care.
Take care. Bye.